I have the wonderful opportunity and exciting to really meet some new folks and new faces and introduce this panel. Now we're going to try and do something a little bit different. Well, not too different. Each one of us is going to go about 5 to 10 minutes and actually talk about an innovation that we're doing or talk about what's happening in the future. I know in the morning you got from Larry and Kristen and a few others how innovation centers and innovation labs are being set up and exploring. But you're going to actually hear from folks that are looking forward, that are going to bring you some technologies that they're trying out, that they have, and how it's going to impact the future. So this is really the session to be in, not the morning session. No, the morning's good. I'm just, is Larry still here? Did he leave? Oh, hey Larry, good presentation this morning. So let's get down to it. Let me make an introduction. We're each going to just dive right in. All right, so our first panelist will be Steve Barlow. He's the co-founder and VP of Client Operations at Health Catalyst. Real quick, as you know, we also have Chuck Podesta. Did I say that right, Chuck? Close enough. Excellent. He's the Chief Innovation Officer at UC Irvine. We've got David Price, Vice President, Medical Affairs from Dexcom. Carol Robinson, Director of Sales, Qualcomm Life, and Scott Weingarten, Weingarten, who's our Chief Clinical Transformation Officer from Cedars-Sinai Health System. So please give them all a big hand, and we'll start off with Steve.
Thank you. We're excited to be here this afternoon. Steve Barlow with Health Catalyst. And Health Catalyst is a analytics and outcome improvement organization based in Salt Lake City, Utah. Had a quick flight down this morning. And we're going to talk a little bit about some exciting things that we're doing relative to predictive analytics. But by way of intro, I'll just say a little more about my background. I'm a data guy. I worked at Intermountain Healthcare for about 18 years. And the last 12 years or so, I had responsibility for analytical services and data warehousing there, supporting Dr. Brent James and Dr. David Burton in their clinical integration strategy. And left about 7 years ago and started Health Catalyst, wanted to take some of those best practices with respect to quality improvement and using information and data to measure and improve care. And that's really what founded Health Catalyst. I have to offer some acknowledgments and credits to my colleague Dale Sanders. He has done some tremendous work in predictive analytics, and he couldn't be here. I'm actually a substitute for him, so all of the really tough questions I'll collect and see that he gets. I did use some of his material for this. So a disclaimer, I'm a pragmatist. In fact, as we went through the process of defining the values and operating principles and cultural attributes for Health Catalyst, I insisted that this be one of those operating principles, and that is pragmatic innovation. I had seen too much in my career really exciting and brain-twisting innovations that had very little real-world value. There's some tremendous knowledge that takes place, and we need those mind-twisting exercises. But our focus is let's identify those innovations that really can make a difference now. And so a pragmatist is someone who is pragmatic. That is to say, someone who is practical and focuses on reaching a real goal. By way of intro, you may or may not have seen this healthcare analytics adoption model with Dale Sanders and David Burton and others have contributed to building this framework. It's really not meant to be a sequential framework, but a tool that organizations can use to measure their maturity using analytics to improve care. And I won't take the time to go through all of these levels, but you can go out and just do a Google for this model, and it's readily available online. Our goal is, what we're finding in healthcare is that most organizations end up at maybe level 2 or 3. And our goal is to help organizations move up this path so we're actually using information to personalize medicine and to predict outcomes. And I'll talk a little bit about what we're doing relative to the latter. This, again, I won't go through this in great detail, but it's the basic process of predictive analytics where in the middle here you start with historical data. Does this pointer work? You start here in the middle with historical data and you match the profile with all of these trends. So this is setting you up for what we're going to talk about. You look at historical trends, match a patient who may have similar trends, and then predict an outcome. At a very high level, that's what we're trying to do. Another disclaimer, healthcare really is not big data yet. If you compare the data in the airline industry, where each flight generates about 500 gigabytes of data in a 6-hour flight, one patient in a year generates maybe 100 megabytes. There is so much that we need to do in healthcare with little data and structured data. There is value in unstructured data, and we see tools coming onto the marketplace every day that are going to help that process, but there's still so much to do with structured data. So we're not going to spend a lot of time talking about big data. So what are we trying to predict? We're working on an application that we call the flight path predictor, using an analogy that airlines use to predict the optimal flight path for a plane approaching the airport and leaving the airport to reduce turnaround times, getting them in and out of airports. We're using that same metaphor in healthcare, and I'll explain here in a second. So we're wanting to predict preventable readmissions for certain conditions. We're wanting to predict severity of certain infections like sepsis. We want to predict the risk of certain conditions and the appropriateness of certain treatments. The list goes on where predictive analytics can be applied. We think there's a lot of good practical scenarios where this can be done today. So here's the idea. If we look at a cohort of diabetic patients, roughly over the last 5 years, we have a registry of about 26,000 diabetic patients. And if you look at the good flight path, the good care, the good treatment plan that they've received, it would show an absence of some of these conditions up on the upper right. Whereas a poor flight path, a poor care pathway, it would show the presence of some of those comorbidities and conditions. This is a screenshot of the tool that we have deployed at a couple of our clients and we're beta testing and working with. And there are 2 layers to consider. The first layer is the layer of identifying a risk score. So if we have this patient containing these comorbid conditions, this profile, age, gender, tobacco use, other behavioral characteristics, we identify and assign a risk score. That's not very new and exciting. We've been doing that for a number of years. The idea then is to look at other patients with similar or slightly different profiles and predict and simulate the outcome of this patient with that same risk profile. So there's a little slider here in the middle. If I reduce or improve the A1C or the LDL or the BMI for this patient, what could the outcome forecast be? Financial outcome as well as a quality outcome. So we're beginning to do some experimenting with these, and so far the clinicians that have seen it have been very excited. Just a couple of thoughts to conclude. If we look forward to the next few years, some of the thoughts that we have is certainly employers are going to be moving more toward a shared risk and a defined contribution model and a value-based payment. So value-based payment model. So the providers are going to want to be very interested and will be very interested in managing populations of patients, predicting outcomes, finding ways to keep those populations healthy. Provider and outcome transparency clearly is already very active. Proactive population management, leveraging data. We talked about big data. There's a lot in little data that we still need to harness. We believe there will be a shift away from relational data storage. And for a while, it will be maybe a hybrid of unstructured and relational, e.g. Hadoop and other unstructured data stores. And the reason for that, the driver, we believe, will be primarily performance-driven and cost-driven. But there's so much invested in the relational world that it's going to be hard to really move away from that too quickly. And this idea that we're also talking a lot about is closed-loop analytics. So if analytics typically is a retrospective kind of endeavor, we need to take the knowledge that we glean through that retrospective activity and fold it back at the point of care in the EMRs and other point of care systems. And so far, some of the EMR vendors haven't been quite as open to that. Others are. But folding analytics back to the point of care with knowledge gleaned through retrospective analytics, we see is very important. And then clearly the predictive algorithms are going to get more and more sophisticated, and it's exciting to see that happen. Thank you.
You can give me a hand. So again, a reminder, we're going to do 4 or 5 more panelists, and then you guys can ask questions. We also have a question for you guys. So let me introduce the evolution of BI, business intelligence, at UC Irvine, and that's Chuck. And Chuck, you'll have to say your last name so I don't butcher it.
Yeah, that's okay. Thank you. Thanks. I'm Chuck Podesta, and I've been at UCI as the Chief Information Officer since September of last year. So when we talk about the evolution of BI at UCI, I'm coming at it all of 5 or 6 months here. But I do want to thank Lisa Dahm, who's over here, my Director of Clinical Informatics, who actually put together a lot of these slides to make me look somewhat articulate up here, which is difficult to do sometimes. So as we look at UCI, we actually, in the University of California system, UCI is actually known for having one of the better data analytics organizations. A lot of it's due to Lisa and her team, and they're already doing. We're already doing quite a bit of forward-thinking analytics and utilizing really state-of-the-art types of technology like Hadoop, and you'll see this as I go through some of the slides. But you can see here on this one slide where we started and where we are today. And if you look at, you go back to I guess it's the ape. And actually, if there's any CIOs in here, we feel like this on the left side most days. I mean, that's where we are. And to be able to, get to the point where we can utilize some of this technology is getting us to the point where, we feel like human beings going forward. But we started with only spreadsheets. We moved to Tableau and spreadsheets. Then we connected some databases to Tableau, and now we're into more of the data-driven alerting using a product called from Metric Insights and Tableau. But right now we're actually moving into a new world, and this is the next great event at UCI with a company called ClearSense, which is a startup. And we view it's going to be game-changing, and Lisa's very well known in the UC system for her knowledge of analytics. And when we bring in vendors, usually the meetings don't last that long because everybody thinks they have the next greatest thing. But at least when we saw what was happening here, it was something that we wanted to move forward with. So talk a little bit about that. In the past, if you looked at before 2011, this is kind of what we looked like, and a lot of your organizations probably were doing the same thing. Maybe you're still doing it today, but you basically had a variety of different databases because we're part of we're an academic medical center. We're also part of UHC. You have your analysts taking that data, moving it to an Excel or other types of databases. Then your visualization tool is either SharePoint, email, or Excel charts, and that's really kind of the old way to do it. There's a lot of organizations that still have data analysts that are really holding tight onto this type of model. So currently, we've moved more into using Tableau and some other tools where we have a data warehouse, and we have a variety of source systems that were connected to it, and then we use Tableau and a dashboard portal to pull this data. But Lisa has a very large team of analysts, as you can imagine, to do a lot of the data mapping from these source systems to get it to visualization mode. Before you can even extract the data, all the mapping that's involved in this is very, very intense. And so what we've been looking for is tools that, not to replace what we're doing today, but really to augment what we're doing. Because just like you, I'm sure you have backlogs of either ad hoc reporting requests, research requests, those types of things, that you could add 10, 15, 20 more people to your organization. And because of this type of mapping technology, really, you're not going to get anywhere. You might impact it a little bit, but not a whole lot. So really what we're moving into, and talk a little bit about the way this works, is that on the left side, you have your source systems, just like you do today. And those could be multiple EHRs, financial systems, spreadsheets, whatever you're using today. And then on the right side is your visualization tools. And again, you want that to be mobile, iPad, iPhone, that sort of thing. And in the middle is really the engine as to what's happening here. And I'm not going to go into it in too much detail, but the way the clinical data warehouse works is very much in a virtualized fashion. So as you're adding storage and you're adding horsepower to drill down on the data, because you want to be able to do it in a real-time fashion, the amount of hardware that you're adding to the ring is very small. And so the incremental cost in this type of model is a lot smaller than in a kind of a vertical stack model at that point. The other thing that's happening here with the data analytics manager is that instead of having the volume of people that you have in doing the data mapping, the analytics manager is actually a combination of some open source tools and some other proprietary coding that actually goes into the source systems and understands using different algorithms, understands that data, and then automatically maps that data. So you're getting away from the point of having all the resources doing all that mapping. So it understands the data, creates the metadata, maps the data. So now when you extract it, it's a much faster process. And then you can use your people more on the validation side and on the visualization side. So the other thing that's happening here as well is on the visualization side, you're starting to give the tools to the user, to the customer, that they now can use, as opposed to always calling the analyst for like the next view, the next view, the next view. Once you create the visualization, it's all drill down capabilities associated with that. It's interactive. The user can be trained to actually create other views using the data as well. And what's really nice about this model is the speed to value. And what we're seeing is instead of months and even years when you set up data warehouses and star schema structures and things like that you're used to, is we're talking weeks to do proof of concepts. We just started towards the end of 2014, so this is all very, very new. And we already have 4 proof of concepts out there, working with the chief medical officer on one, chief financial officer on another, and it's going extremely well. But what we're investing in right now is really this engine piece. It's really not a product yet, and we really have to work on that aspect of it. So we're hoping to work closely with this company to get to the next level. This happens to be, it's hard to see, but if you get access to the slides, you can see them at some other point. But this is a census dashboard. Truly, you can drill down on any one of these points. This was created in about 3 weeks, pulling data from many, many source systems to do that. If you know UCI, just to give you an idea, we're all scripts from an electronic health record. We're an old Siemens Envision from a hospital billing standpoint. We're also a GE IDX from a physician billing standpoint as well. So it's very, very old technology. So these source systems, it's very difficult to map that data, and to be able to do it in a dynamic mapping format is truly unique. The next one is transfusion, blood transfusion. And again, when you do a blood transfusion, you look at vital signs at different points along the way to really get an idea of how the patient is doing. So this is real time again. You can drill down capabilities associated with that. And I'm not going to go into these in too much detail. I'm just trying to show you the power of the system. This last one happens to be just a medication list from an inpatient. All the top 10 medications are being used in the hospital on a given day, week, month. Again, all drilled down. Different types of visualizations, as you can see. Again, all this is created within 2 to 3 weeks of actually turning this engine on. The last one we're working on right now is PQRS on the ambulatory side, which you can imagine that's difficult to do with a large. We have over 500 physicians that we need to report on. It's about $200 a doc per year to do that. So we're hoping to utilize this project to really centralize that PQRS reporting going forward. And then we have a lot of other plans as well. But to me, the true innovation is around the dynamic mapping and around having software do the work of what people were doing today. So to me, that's really the next step, and really disruptive in my mind. And I think Lisa's here as well. If you want to get more details around it, she's here and can talk to it much better than I can at this point. So that's it.
So a lot of information to absorb, but keep your notes coming. Our next moderator is David. Our next presenter is David. David, come on up. Give him a hand.
Okay, I'm blessed. I happen to work for a company called Dexcom. Dexcom makes a continuous glucose monitor, and continuous glucose monitoring, many clinicians believe, is the most important advance in the management of diabetes since the discovery of insulin. And what I'm going to do in the next couple minutes is talk about where we were, where we are, and where we're going, a challenge in a brief period of time here. So why is continuous glucose monitoring so important? It's so important because every person who uses insulin is at risk for hypoglycemia. That's glucose is falling too low. Every person with diabetes has to make decisions throughout the day about what they should eat, how much they should eat, the impact of exercise. They need to be predicting the future. CGM does this for them. So the current practice involves blood glucose monitoring. What does that mean? It means a person with diabetes, in order to get the information to inform their decisions, has to prick their finger. By the way, that hurts. It's not fun. It takes work. They have to think about doing it. How do you do that in the middle of the night? Parents actually walk into the rooms of their kids and often prick their fingers when their kids are sleeping. So it is a blood test. Now, with continuous glucose monitoring, with a push of a button, you could see where the glucose was and where it is. So for example, you could tell that the glucose is 220 and rising. So if you're seeing that at bedtime, you're probably going to want to take an extra dose of insulin in order to have better glucoses overnight. Or you could see that the glucose is 220 and falling. So you probably would not take a correctional dose of insulin. And again, somebody who does a blood test, all they know is they're 220. God, what do I do? There's a lot of uncertainty. So what is this continuous glucose monitor? What it is, it's a biosensor. It is FDA approved. We're on our 4th generation, and our 5th generation, which I'll be showing, has been submitted to the FDA. So what it is a small sensor wire. You could see that at the left. Many people describe it like a cat's whisker. It's really flexible, it's really small. A person with diabetes deploys that under the skin in their abdomen. It stays there for 7 days. And again, we're going to be getting to longer duration. The transmitter, which says Dexcom G4, snaps in above the sensor, and the data is sent to a handheld device, the receiver. So again, a person could look at their receiver and know where their glucose was, where it is, and the direction it's moving. The average person with diabetes on insulin does 4 or 5 finger sticks a day. The average person interacts with their receiver 25 times a day. Again, we're on our 4th generation device. This device was approved in 2012, is approved down to age 2, has been combined with insulin pumps, and we've improved it recently with a new algorithm. What this slide shows is how far we've come. It's the accuracy improvements. Accuracy is critical. If you don't believe the numbers, if a person with diabetes doesn't believe it, they don't act on it, they don't use it. These numbers that in this graph are a MARD, mean absolute relative difference. Small is good. The diamond to the right shows the performance of our current system, which basically shows that we are now equivalent to many blood glucose meters. Now we're integrating with mobile devices, trying to make the diabetes actionable even more actionable both by patients. Because how many times do people interact with their phone a day? Is it 25 times a day on a receiver, a phone? You know, I've seen some data 150 times a day. So it's a lot more actionable for people with diabetes, and it allows sharing the data. So our first venue to share data is a product called Dexcom Share, which is now obsolete. It was just approved a few months ago. The receiver fits into the cradle, which is plugged into the wall, typically at night. And the data then goes to an iOS device, gets sent to the cloud, gets sent to a parent's or a loved one's or a caregiver's iOS device. So that means if my kid had diabetes, I could be in my room, I could wake up at night, I could look at my phone, I could know what their glucose is. If I'm traveling around the country and my wife had diabetes, I could look at my phone and know what her glucose is at any one point in time. I could get alerts if the glucose is too low or too high. So we've just had approval for moving the Bluetooth connection into the receiver. So now the Share is now mobile. So people with diabetes could be sending their glucose data to caregivers, to loved ones on a continuous basis during the day and during the night. So again, the data goes from the, went the wrong way here. So the data goes from the receiver into the cloud, into an iOS device. So we've moved from a standalone handheld into a cradle, into a Bluetooth connection into the receiver, but we want to get rid of the receiver. So we are moving our way into the phone. This was just submitted to the FDA this past week. It's a PMA, which means we anticipate the review to be 6 to 9 months. The glucose data now gets into the phone. So it's the same little sensor wire connected, a transmitter snaps into it. The data gets sent into the phone, and from the phone it could be sent into the cloud. From the cloud, it enables the ecosystem. So we're sharing data with a number of partners, with pump partners, with data analytic companies. Again, the possibilities are endless. So continuous glucose data is being sent into the cloud and could be used to help inform better management. We're also sending it to our own software called Sweet Spot. What we do with our Sweet Spot solution is do some basic analytics. So we have an idea of what the hemoglobin A1C would be. We could define risk categories. We could determine compliance. We look for patterns. So for example, if somebody's on a new medication that costs $10 a day, we could quickly see if they are responding. We could determine from our data analytics if somebody is at high risk because they're having a lot of lows, or if somebody's staying high, or if somebody's non-compliant. So again, our moving into the cloud enables very rich analysis. What we're then moving into, and we're in the clinic for right now, is the next generation. This is going to get rid of the need for calibration or greatly reduce calibration. It's going to get rid of acetaminophen that right now interferes with our measurements. When we get rid of acetaminophen, that opens up the hospital environment for us. We're going to have extended duration. So what are we trying to do? we're trying to replace blood glucose meters. We're trying to provide glucose information to really empower people with diabetes, empower their caregivers, and empower health systems. So thank you.
Just real quick, how many of you know someone, it could be yourself as well, but know someone that has diabetes in the family? So that was a pretty impactful presentation, I think. Our next presenter is Carol from Qualcomm. Come on up, Carol. Give her a hand.
It is a pleasure to be here. It was, when I got here, I recognized, I think, about a third of the people in the room. It was a lot of fun. I think everyone knows Qualcomm as a leader in mobile, and Qualcomm Life is a wholly owned subsidiary of Qualcomm focused exclusively on healthcare. So if you think about Qualcomm, everybody thinks of the chipsets, but virtually every smartphone, every tablet throughout the world has our technology in it. And what better place to be able to impact healthcare than working in a mobile world? And so for us, we really believe that mobile is transforming healthcare. You saw it today in many of the presentations, some of the speakers. You know, we're surrounded by this network, right? Mobile network, but we're soon going to be part of that network if we're not already, by virtue of the wearables, by the things that are going to be attached to our clothing, patches that are going to be able to be worn for a few days that can detect all kinds of biometric information. We're working on some, lots of other companies are as well, and at a fraction of the cost, can you imagine being able to monitor blood pressure, pulse, all those kinds of things by a little Band-Aid kind of a patch that can then be taken off and worn after a few days. So we'll become part of that whole mobile network, and that's what we see as part of the next transformation. There is no faster growing industry right now than mobile. It's huge. Back in 2012, there were 10 billion connected devices. By 2020, there will be 25 billion connected devices. And many of those are not just in populated areas. Even underserved areas have adopted smartphones and that kind of technology, and it changes the way we interact with each other as well as the way we interact with our health. When we talk about frictionless business processes, and kind of the summation of this is mobile has been adopted by virtually every business in the world, whether that's banking or healthcare or auto industry, and probably one of the best examples of a frictionless business process is what we heard about earlier today. It's the Uber experience, where you literally can press one click on your phone and a car literally knows where you are, comes and picks you up, takes you where you want to go, and charges you like that. That's frictionless. But that's also where we want healthcare to go. And how do we do that? For us at Qualcomm Life, one of the first technologies we developed, we've been around about 3.5 years, is a platform called TueNet. These are the hubs. These are now also available in your phone, and they connect via Bluetooth with all kinds of biometric sensors. So they have the radios, they search out the sensors that are around them and can then upload those sensors and send them to your clinician, or to, for us, our case, we also have a care management solution, to the care manager solution. So lots of different ways that we can make an Uber experience. Why do I say this would be like that? You literally plug it in and it works. That's called frictionless. That's where we're trying to go. There's a tremendous amount of push and pull in health. You heard a lot about it today. You know, managing risk populations, the whole volume to value transition that we're still undergoing, and we're in some midst of that. For Qualcomm, we're focused on the bottom three of these. Consumerism, what patients are demanding. They want that Uber experience, so we focus a lot on that. And also the whole shift in care. It definitely is moving out of the hospital into the home. You talked, in fact, we just heard from Jim earlier at the Kaiser, how do we take that visit to the home? How do we find ways and technology to do that? And then we work with a tremendous amount of other technology companies and trying to mature their technology that can use our platforms. Lots of very forward-thinking healthcare systems, we work with many of them, are using the power of mobile. And they take from just that patient health record, we now have care management platform. For us, we brought on a company about 2 years ago called Healthy Circles. It's basically a white label tool that allows you to do asynchronous communication with the patient, the caregiver, could be your brother or daughter in another state, all of the providers. It's managed by the patient and allows you to take that same biometric data and marry it with things like symptoms. Things like, did you take your medication or not? So you can actually construct care sessions, if you will, and be able to manage more than just the biometrics. And then that allows you to spend the time that you need managing those very high-risk patients for the least cost and the most ability to make an impact. Talked about the patient, the point of care being shifting. It's definitely shifting home, and we are working with companies that actually take the smartphone, I think one of my slides left, but the smartphone technology with attachments. We saw one earlier, I think in Jim's slide, that literally can put an attachment. A mom can literally take it to her child's ear. It uses the camera and the LED, part of the phones that we also control, and allows that picture to be taken of the tympanic membrane, the walls of the ear, and a diagnosis to be made as to whether the patient has otitis media, needs to come in, needs medication, and they can literally do that from their home. There are many other companies out there doing very similar things with stethoscopes, with all kinds of work, and we're trying to enable them and use the wireless work that we have and the ability to send data virtually anywhere you are to wherever it needs to go. So bold answers and a lot of big challenges. It's not easy, but it's a lot of fun. Thank you.
Man, it's getting exciting, isn't it? You guys should be excited by now. So for one of our last panelists, I'll bring up Dr. Weingarten to present from Cedars-Sinai. Give him a hand.
Thank you, Sajid. Good afternoon, everyone. How many of you from provider organizations? Terrific, good. Well, for those of you in provider organizations, your electronic health record is now live. And what do? You know, how do you ensure that there's a clinical and a financial return on investment? Federal government spent between $30 and $36 billion to subsidize hospitals and physicians to purchase electronic health records. They are expensive, whether you're a physician in practice or a hospital, and the data is fairly conclusive that electronic health records alone do not improve care. You have healthcare providers and physicians typing when they had been handwriting, and that will result in some benefits, but it's really tip of the iceberg. And for those of you in provider organizations, you went to your board of directors and you asked for a very large check to purchase an electronic health record, and that was probably unusual for your board of directors. The board of directors had not been used to a request for a check that large without ending up with a new building with someone's name on it, perhaps a donor. But there's no new building. There's just an electronic health record. And there's really an opportunity, and I'm going to talk a little bit about clinical decision support and some work we did at Cedars-Sinai, where clinical decision support, if you provide context-specific clinical information to healthcare providers while they're seeing patients according to the literature, systematic reviews, meta-regressions, meta-analyses, you're 112 times more likely to improve care than if you don't. 112 times more likely to improve care. And again, if there were a pill that came along that was 112 times more effective for treating heart failure and equally safe, it would become a blockbuster. So we liken this to an accident avoidance system. How many of you have a blind spot monitor on your car? A number of you do. Okay, I do too. And for those of you who don't, when there's a car in your blind spot, it flashes or it lights up, and then if you turn on your turn signal, then it could flash. Now, as a driver, you can still change lanes, even though there's a car in your blind spot. You have complete autonomy. It may be inadvisable for you as the driver and for the person in the car next to you, but you have complete autonomy. And that's what we tell our physicians at Cedars-Sinai. We have 2,300 of them. This is just to advise you, but you do what you think is best for the patients. Now, accident avoidance systems work. If you look at liability claims, Mercedes and Acura, it reduces accidents. And actually, clinical decision support, the literature, it's been around for 30, 40 years. It shows it improves care. So, great opportunity. The American Board of Internal Medicine and 60 physician subspecialty organizations representing over 500,000 physicians have defined clinical waste, meaning the harms exceed the benefits or there are no benefits. This is a huge opportunity. It's a landmark event. Your physician colleagues, and those of you who are physicians, got together and said they want to help solve the healthcare affordability crisis, really for the first time in healthcare. Now, how do we leverage? We have this new physician initiative from over 500,000 physicians, or organizations representing over 500,000 physicians, and you spent a lot of money on your electronic health record. How do you bring this together? It's for the inpatient setting and the ambulatory setting. So what we did at Cedars-Sinai is we decided, kind of like the old Reese's peanut butter cup, chocolate and peanut butter, put them together and see what happens. We did this about a year and a half ago, and we went live initially with 120 clinical decision support recommendations on one day. On one day. Actually, it was the idea of the chief information officer at Cedars-Sinai, a guy named Darren Dworkin. He said, let's do it all big bang one day. We had been doing 1 or 2 a month up until that time. He thought it was a good idea, and it turns out I think he was right. So we now fire for all of our physicians, the medical group, some of the physicians in our IPA, virtually all of the physicians in the hospital, about 300 alerts each day. And again, this has been going on for a year and a half. Our physicians are not shy. We really haven't had significant complaints yet about this. Some of the physicians might have written the alert a little bit differently or may not agree with their subspecialty society, their interpretation of literature. But again, we've been doing it about a year and a half. So we started with soft stops, where you just put something in front of physicians, but they don't have to write anything, they don't have to click on anything. And here are some examples of some of the alerts. And what happens is, if you look at it, you just do a soft stop, physicians change their behavior. Now you could say, well, gosh, Scott, that's 8% to 23%, but that results in real benefits, which I'll share later. And we said, well, we can do better than that. And what we did is we looked for false positive alerts, because physicians hate false positive alerts, alert fatigue. You all are very familiar with it. And we said, whenever the false positive rate is below 40%, or the positive predictive value is over 60%, is it okay if we transition to a medium stop where physicians have to offer input? And we brought that to all the various physician committees at Cedars-Sinai, and there are quite a few of them. And they said, okay, if the false positive rate is that low, go ahead. And we did. And again, it required multiple iterations, changing the alert, changing it again, changing it. False positive rate, under 40%. And you can see when you go to medium stops and you require user input, physician has to type something. They can type anything. Additional benefit, significant additional benefit. So we were glad we took that step. And you can see the percent change when you go from soft stop to medium stop is anywhere from, 19% to 65%. So we're going to continue soft stop to medium stop where the false positive rate is low. Again, we talked about EHRs are expensive, and somebody someday is going to ask, what is the return for these things? Again, written a very large check. What did we get in return? And so we've been tracking with all of these the reduction in inappropriate care from choosing wisely. Here's an example of inappropriate carotid imaging studies. And you can see over time statistically significant reductions in inappropriate care. And I could share graphs like this for all 180, which are now live. Started with 120, added 60. Savings of almost $4 million a year so far, and we're still on our journey going from soft stops to medium stops. We expect much greater savings. Again, single hospital, medical group, and some physicians in the IPA and private practice physicians. We worked with Stanson also, and let me just share with you some real data from some of my physician colleagues at Cedars, good doctors. Here's a physician who ordered 6 Lyme disease tests for patients in a 3-day period. There's some physicians here, right? What do you think about that? Is that a good idea, bad idea? I need some help here. Bad idea. Why is it a bad idea? Good question. Why? And we asked that question. Is there Lyme disease in Southern California? I need some help. No. Okay, if you go to the LA County Department of Health website, confirmed, operative word confirmed, Lyme disease in Southern California, for people who do not leave Southern California, how many cases per year? Actually, 1. I don't know how that happened, but 1. How many people are in LA County? 10 million. That's right, lots. So 1 out of 10 million. So we shared with the physician, a patient is more likely to get struck by lightning, bit by a shark, or significantly more likely to be injured by a vending machine. Turns out we get really angry when the candy bar doesn't drop. Man versus machine, the machine always wins. So this doesn't make sense. You're going to find lots and lots of stuff like this out there when you look for it. Another example, we had a physician who was ordering vitamin D levels just for screening purposes, population health screening, on all of his patients, or virtually all of his patients, who came in for physical exams. He said, choosing wisely, your physician colleagues recommend against it. And we provided the information. It went from 34 a week to 1 a week. Now, what is the benefit? All the data I've showed you are real. This is a projection based on the data, the literature, the clinical epidemiology literature. And this has to do with benzodiazepine use in the elderly. Benzodiazepines in the elderly increase the risk of falls, hip fracture, death, and motor vehicle accidents. So we reduced benzodiazepine use. Benzodiazepines, by the way, are Valium, Ativan, Ambien. You're familiar with all of them, sleeping pills, sedatives. But we reduced benzodiazepine use 31% in elderly patients. Okay. If you look at the literature, you need to track it. If you do that in your population, or in our population in this case, over a 1-year period for elderly patients, you should expect 22 fewer fall-related injuries, 6 fewer emergency department visits, 3 fewer hospitalizations, and 2 fewer deaths. So it's an opportunity. You're reducing mortality, so improving quality of care, and reducing costs. Reducing avoidable hospitalizations. We actually had one of our vice presidents stand up in front of all of the physicians and describe when she flew from LA to Florida to see her mother. Her sister called up, said her mother was unresponsive in the hospital. She boarded the plane, thought her mother was going to die. She landed, called her sister, and her mother's now playing cards in the hospital in Florida. Turns out a physician gave her elderly mother a benzodiazepine. The vice president, non-physician, told that story in front of all our physicians. Very powerful, very helpful. So to finish, again, basically went live, 180 clinical decision support recommendations, 2 tranches, thanks to, in part, a courageous CIO, and the savings about $4 million a year, substantial improvements in quality, mortality, and morbidity. So when we're asked by the board of directors, we spent a lot of money on this electronic health record, promised all kinds of benefits. What are the benefits? We now have a story to tell. Thank you very much for your attention.
So you've heard 5 very powerful presentations. I'm going to just present on the hospital, but before I do, the brand new hospital we're opening in South Los Angeles and some of the innovations we're doing. But before I do that, how many of you are quote unquote in IT? Just raise your hand. IT? Yeah, it's a safe question to ask at a Health Information Management Systems Society meeting. I just want to take a few seconds here to mention when I showed up to one of these, I think 5 years ago, a number of us were talking about, wow, look at how much time has passed. It's been 5 years. 5 years ago, or a little over 5 years ago, ARA was passed, the HITECH Act was passed in February of 2009. We were all launching regional extension centers to support electronic health record adoption, and I think back then Candy Crush was also launched sometime. My point is that part of the innovation that I think you've seen here and what I'm going to talk about for our hospital, because someone asked me and I said, you know, I don't have it in a slide, but I'll say it out loud. They asked me, what's the most innovative thing you're doing, Sajid, at your hospital? And as you know, this whole topic is about innovation in healthcare delivery. I said it was culture. Culture is the number one innovation that we're doing at our hospital. And part of that means that we're, besides focusing on patient care and how we treat each other as employees, having a culture of innovation, one of the things I wanted to share with you, and the reason why I asked all of you to raise your hands if you were in IT, is I want to challenge you to say that you're not in IT, but that you're in health IT. Health information technology, as Dr. Weingarten just mentioned, a lot of it has to do with partnerships. Well, in this case, Darren Dworkin's easy. He's a very powerful CIO. But it involves a combination of clinical and IT working together. So I challenge all of you to test the old rhetoric of, hey, you're just an IT guy. No, we're really getting involved in the delivery of healthcare. So I wanted to leave that before I start. What do you guys think about that, huh? Not too bad? All right, good. Yeah, I was on my soapbox here. So since you guys have all been sitting politely, I thought maybe the best way to share about the hospital is to show you, out of my 8 to 10 minutes, a 4-minute video. So I'm going to share that with you right now.
Today we celebrate the first phase of the opening of the hospital. The new MLK is not just a reopening, it's a reinvention. It's a miracle.
We're wrapping up the installation of our state-of-the-art equipment that will make our hospital a leading model of innovative, collaborative community healthcare.
We will provide first-rate healthcare to the people of Los Angeles County like never before.
I'm in awe of this event. I remember it last year, and I thought it was completely full, and now it looks like it's doubled in size.
You are your brother's keeper. To be human means to care for one another. This was the dream that Reverend King lived for, and the dream that he died for.
Did you know that true love asks for nothing? Her acceptance is the way we pay. Until the rainbow burns and stars out in the sky.
And Engager is an example of commitment to community, to health. Our community engagement honoree, Forrest Whitaker, is all of those things.
As you know, today is Martin Luther King Jr.'s birthday. He would have been 86 years old. Today and every day, he still speaks to us. His voice, echoing in all of our own minds, inspires each of us to ask of himself or herself, am I doing all that I can do to help my fellow human being? South Los Angeles is one of the most vulnerable communities in the nation. If we do not help these people, what will happen to them?
Now please join me in thanking our event co-chairs, Linda Griego and Candace McKeever. There's no doubt that Candace is central to this event and so many other efforts that led to the success that we see here today. We miss you, Candace. Hurry back soon. There's a lot of work for you to do.
As we celebrate today the accomplishments of the MLK Health Foundation, celebrating the dream, I'd like to present this to Dr. Cynthia Theus.
It won't really matter that we've made it individually unless we made a difference for those around us who've been left behind. Our city can become a model for weaving together our various colorful, contrasting, at times clashing threads into a strong, healthy social fabric.
This dream is of vital importance to the people in the community we serve.
Our destinies are inextricably interwoven.
Martin Luther King is smiling down on us. Lives have been saved.
His hospital will tear down the walls that hold back people in this community.
And as Mother Teresa said, may we be somebody to somebody else every day. Amen.
Let me share with you some of the pragmatic things we're doing at Martin Luther King Hospital. As I've said, this has probably never been a better time to be an innovator, and we're taking the advantage of this brand new hospital, brand new buildings, brand new staff, brand new organization. I was hired on as employee number 2. It is on a 40-acre campus, roughly, with the Department of Health Services, Department of Public Health, Department of Mental Health. There's a magnet high school for health and medical sciences. There's a medical school across the street, and we are the private side of the public-private partnership with LA County. What we hope to do, and what we planning to do, and in fact I was inspired by Larry and Molly Coy and a bunch of others a few years ago at an innovation summit in DC, we said, we've got this great opportunity. Once we open the hospital, what are the things that we can do, that we should do when we open the hospital? How can we innovate? So these are some of the ideas we had. Definitely coordinate care, definitely use technologies such as telehealth. A lot of people said, well, isn't telehealth for rural? I said, no, it's for urban too, it's for here. We want to connect with doctors at UCLA, at USC, at Cedars-Sinai, at Kaiser. And all of them, by the way, have helped in their own way in helping us launch this hospital. We also looked at our community of providers, health plans, long-term care agencies. And this is a great graphic. It shows you not only who our hospital transfer care partners are, but who we're going to plan to coordinate care with. And we may just focus in on the campus first and exchange data with the county. They have a Cerner instance, we have a Cerner instance, no brainer. But we hope to expand into coordinating care, sharing data with many of these provider groups, health plans, and long-term care agencies and other hospitals. So this just outlines the approach, not just coming up with an initiative and saying, let's launch it, let's pilot it. We're actually looking at getting into the contracts. While we're developing these new contracts, transfer agreements, we're saying, hey, maybe not right now because you may not be ready, but in the next 12 months from when we open, we want data sharing to be in the contract. We want your commitment to workflow reengineering of your business practices and our business practices to enable that data sharing, to make it viable, to make it practical. And of course, the dream, the vision that I have that I'm hoping Larry and many others, Kristen, Molly Coy and others from UCLA will help, is we're planning to launch a healthcare transformation center on the campus, anchored by the hospital, that will hope to innovate at what I like to call the micro layer, which is within the 4 walls of the hospital, maybe with the outpatient center that's owned and operated by the County of Los Angeles, at the meso layer, which is right there on the campus. How can we integrate and work together? And at the macro layer, how can we innovate and transform with the community? The community is fully engaged. They're really excited we're here, and with many of the community stakeholders, how can we create that innovation hub at MLK in South Los Angeles? And of course, we have to strike a balance. We're about 2.5 months away from getting our hospital ready for licensure and opening the doors for the very first time for patient care. And so we're trying to figure out, well, what can we prioritize to do now that's safe, that's effective, that promotes a positive culture of patient care right now, open the hospital, and what can we plan for in the future? So I want to mention a couple of key things. We're looking at this from a completely ground-up fashion. Pre-hospitalization, what do we do with patients? We're thinking of using technologies like e-consult, maybe even telehealth, to have primary care providers contact our hospitalists and say, hey, I've got a patient that I'm about to send to your ER. Maybe we can triage that using the mobile app tools, the asynchronous communication, alert platforms that would send, even if the patient is admitted, that would send alerts back to the primary care office and say, hey, we just admitted your patient. You know, we want you to know, we want you to be aware, and this is what we're doing. And of course, post-discharge, we're looking at using an MLK app that's in development right now where we can give discharge instructions right there on the app, but not just here's some instructions, go home. Through content management services, we're going to contact each and every one of those patients and say, did you take your follow-up meds? Have you seen your follow-up appointment? How are you doing? Yeah, we can market to them, we can send them health education, but we really want to do this really proactive patient engagement. So these are some of the ideas that we're looking at implementing now. And what I can tell you of some of the cool things we've already done inside the hospital. So yes, we're a Cerner shop, and we're going big bang with Cerner, but we're also pushing with Cerner innovations such as using iPhones. Every nurse and every doctor that's working within the hospital will have an iPhone. That's a brick outside the four walls, but within the four walls of the hospital, it will communicate patient information, alerts, code blues, all those things. We've bought over 163 iPhones to give to all the nurses for all the shifts, to rotate amongst all the shifts and all the doctors that would attend. We're also looking at a patient interactive system that we've implemented. In every room inside the hospital, there's a 42-inch flat screen monitor with the ability to deliver patient education, menus, even to use for communication with family members. The entire hospital is both wired and wireless, high-density wireless to enable over 45 different device types that are communicating on our network, wireless devices that have freed up the ORs. So none of these cords hanging around everywhere, and we're very excited. Some of it's so new that we're doing quality checks day in, day out to make sure that it's safe for patient care. This is pictures of some of the cool stuff. When you're starting a hospital from the ground up and you get a chance to build a ground up budget, though in our case the venture capitalist is the County of Los Angeles, so we had to be very careful. It is public dollars, it is a public investment. But having that flexibility really gave us an opportunity to not only get the best equipment and the best services and working with the best vendors, we got a chance to right-size it, make sure it's right for the hospital, and make sure that it fits the real innovation that we're doing, which is best practices and workflows, really pushing the barrier on how to deliver that care. This is screenshots from inside the hospital. I really recommend, I don't know, we don't hold standard tours, but many folks have said, hey, can we come see the hospital? And we've been open to it. It is frankly beautiful. We've had Kaiser come in and take a look at the hospital, do a checklist walkthrough with us. They've just loved it. And there's 131 beds inside the hospital. They're almost all private rooms for patient care. And so I think the community is really excited. And we are providing, I'd say, I don't want to put Cedars out there, but if those of you who've been to Cedars, we're providing the level of care, the level of facility that a UCLA or a Cedars would provide for a community in the middle of South Los Angeles that hasn't seen anything state-of-the-art. Now, I will tell you, many folks, I'd say about 50-50, when I said, hey, I'm going to take this new job on at MLK, this is about 2 years ago, 2.5 years ago, I had half the folks, good friends and colleagues say, are you crazy? You're going to ruin your career, don't do it, it's just don't touch it. And I had the other half say, wow, that's exciting. And I think sometimes when you innovate, you really have to take that challenge. And I think what you've seen here with all the presenters and panelists that we're going to open up to questions, and I have a leading question for them, is you really have to take that challenge, but I like how Steve said it, be pragmatic in your approach. And a lot of this couldn't be done. This is a HIMSS event, and vendors kind of help support the conference. I want to let you know that we've had to be in the trenches with many of these providers, from top-tier consulting, Cerner, Worldwide Technology, Cisco. I think we have Rez and Imprivata. I tell you, about a year and a half ago, every vendor loved me. Every vendor came to me and said, you should buy our stuff. But without some real skin in the game from these folks, we couldn't be at where we are at right now, which is on the precipice of opening the hospital in a very successful way. What I'm transitioning to is, how many of you know the Gartner hype cycle? You guys, many of you are familiar with. So I have a question that I'm going to start off with for the panel. And you each heard them present on a particular device or technology or software or an implementation. And I'm going to ask them where they, what did they think, and any of you can jump in, what do they think their innovation or tool lands on that hype cycle? And I've put up there the 2014 hype cycle. I think there's a 2015 that's been already presented, but I didn't grab that one. So for any of you that are out there, where do you think your technology or your approach or software or implementation lands on that Gartner hype cycle? And after that, we'll open it up to questions for you guys. If if no one jumps in, I'll just call out a name. I've been practicing memorizing your names. Go ahead, David.
Sure. Is this working?
You might have to turn it on.
Okay. Nope. Didn't help? Yeah, okay, there it did. We are clearly past the trough of disillusionment. So when the first generation continuous glucose monitor came out, I believed in the promise, invested a lot of my own personal money, and it went away. So again, the accuracy and performance just weren't good enough. We are clearly on our fourth, soon to be our fifth generation. So we're rapidly rising up the slope of enlightenment, past the early adopters into the mass market.
Cool. Carol, you've got some cool stuff.
We do. We're on the earlier part, so we're in the innovation trigger side and probably around the area of the biochips. So we're still with early adopters, still kind of proving that it is all there, and now commercializing it to healthcare organizations.
Anybody else? Go for it.
Sure. I think, there's two pieces of this. One is the industry itself with data analytics and big data. I think that's actually moving into the trough of disillusionment. I talked to a lot of CIOs across the country. They spent a lot of money on different tools, maybe not understanding exactly what problems they were trying to solve, but they're to the point now where they're throwing up their hands as to, is there a solution out there that's not cost prohibitive, doesn't take, 2 years to implement, that sort of thing. But the innovation I talked about with ClearSense, which is actually in the innovation lab, if you get a chance before the end of the day to stop by, I view that as on the innovation trigger side of the data analytics at this point. I think it's new and exciting and has the opportunity to get the industry to that slope of enlightenment, I think.
Excellent.
Two parts here. First has to do with clinical decision support. It's been around forever. There are articles showing clinical decision support work, 30-year-old articles, 40-year-old articles, hundreds of articles. That's not new. I put it on the plateau of productivity. You put it in there, you can improve quality, reduce cost. However, we were proceeding with glacial pace, and we kind of calculated at 1 to 2 per month. It could take 50 to 100 years before we would get the benefits that we wanted. And so what is really new is this big bang approach, 120 new alerts on one day, and I would put that as brand spanking new under innovation trigger. What's triggering it is the market is moving. The market won't let us continue to implement 1 or 2 clinical decision support alerts a month. We have to go quicker.
It's moving quick. Scott, go ahead and turn on your mic if you can for the next time. Go for it, Steve.
I'll be real fast. I think healthcare analytics in general is, like my colleague here has said, is moving toward the slope of enlightenment. But I think predictive analytics is very, very new. There's so much still we need to learn, and that's clearly on the innovation trigger side of the slope.
All right, cool. Are there questions from the audience after this exciting presentation? Oh, there's got to be 1 or 2. I've got 1 or 2 in my hand, but anybody? Oh, excellent.
Hi, Jay Lee from Memorial Care. One of the questions that I have that I think is really a challenge for many of us is okay, you've done the innovating piece. How do you scale that? And how do you create spread within an organization? Because I think oftentimes what we see is innovation efforts kind of get really exciting and then they get to that trough and then they sort of die off. But in terms of on the delivery side, how do we scale the innovations that we saw in the innovation lab and these kinds of things and take it up to a level where we're able to be using them at the clinical point of care?
That's an excellent question. You guys want to take that one? Scale? Anybody?
Go ahead. I'll jump in. I think you have to start slow with the proof of concepts. I think you need to pick 1, 2, 3, 4, whatever they might be, things that are impactful to your organization that, if you're working with a startup or new technology, as you see in the innovation lab, most of those are early in their kind of maturity as companies. And, do a deal with them in a way that it's low-cost dollars to do these proof of concepts, get your chief medical officer excited, get your CFO excited, your COO excited around, these different types of solutions that can be out there, and then it'll scale on its own based on that. We're already seeing, excitement within our organization just in the small proof of concepts that we've done today, and a lot of that's because of the speed to value. We're talking about, an idea that the CMO has, and within a couple of weeks, we're showing him something. He's never seen that type of speed before in a technology. So I think, from that standpoint, and I also think it's imperative on the data analytics side to really look at the next generation, because with wearables and sensors and everything you heard about the data that's being collected in a real-time fashion going forward, we have to have a tool to be able to aggregate that data and to be able to report the important parts of that data. And we're not going to be able to do that with even the platforms that are being used today. So I think it's imperative that we look at these types of technologies and try to get them to market as quickly as possible.
Scott or Carol?
I was just going to say, I think for Qualcomm Life, we've been doing this about 3 years. We've done a lot of proof of concepts, and we're really trying to get to that scale now. And I think what's helpful for us is to really think about partnering with a few people that can really scale and make sure that you do it well. If we partnered with everybody that wanted everything that we do, we'd fail. And so being able to be wise about how we do it, especially at this point in our growth phase, is very, very important. But I think to the point that we were just talking about, if you do it well and you get a few of those people really, that are early adopters, early leaders in this world of health, it's going to take off. And that's what we're kind of seeing.
And we also scaled. There was a lot of communication. We presented, I want to say, to 40 to 60 physician meetings. Lots and lots of dinners, lots and lots of lunches, and we discussed this. And we also said, as I mentioned earlier, the market is not going to let us go slow. We got to meet the market, which means we have to scale, and we have to scale quickly. And we got permission from our medical staff to implement all of the Choosing Wisely recommendations, again, 120 at a time, which was a key strategic decision. In a batch, we were able to scale it. Had we instead gotten permission to debate each and every recommendation, we would still probably be on recommendation 7 rather than have 180 live now for 18 months. So we're very, very grateful to the medical staff for allowing us to scale.
So there's a bit of a dichotomy here. In some cases, it's good I like the speed to value, to create that value and then scale naturally. And then you're, Scott, saying you have pressure sometimes where the market it wants you to scale fast to achieve that value. So my question to you guys and also to anyone in the audience, what's your experience has been with scale? Because I think that is a preeminent question. You come up with a great idea. You may even get to pilot it, and there's 2 types of pilot for proof, and then pilot to try it out and maybe scale. Is there a right or wrong here, or is it just based on perhaps the culture and or the type of product or service you're trying to scale? Do you guys have any thoughts? And also, if there's anyone that has a comment, you guys can grab a microphone and help answer that question as well. But I'll offer it here. Go for it, Steve.
A thought is, it needs to be like what has been mentioned, it needs to be both a top-down and a bottom-up kind of approach. If you look at the variation in care delivered, so why do we have variation in outcomes and treatment plans for the same DRG, severity-adjusted DRG of patients? Let's identify the early adopters who will be the thought leaders to define this is a standard of care or this is a new piece of technology that we should deploy. That's the bottom-up portion. Then let's get leadership at the top to say, okay, we agree, you are the thought leaders. Now let's diffuse this across the organization using Rogers' theory of diffusion. Get the early adopters, leadership from the top. I think that's the best way to approach it.
Anybody else? David?
Yeah, I think what Dexcom has really worked hard to do is understand barriers, and that's barriers across the ecosystem. So what are the barriers for patients? What are the barriers for physicians? What are the barriers with clinicians? What are the barriers with payers? And then systematically attack the barriers, and with that comes success.
Anybody else in the audience have a comment on scaling? All right. I have a question, a follow-up question. We've all heard, I mean, you guys all presented great ideas that you've innovated on and presented that's been adopted. My question, and it's similar to what we've been challenged at MLK, is it the technology that drives the workflow, or did you have to re-engineer the workflow, or maybe in case, in David's, the culture and the use and adoption of a tool like that, but did you have to change workflow in any way to get that adoption, to get that scale? How did you address workflow is probably the better way to ask that question. So, anybody? Go for it, Carol.
Go for it. I think working with both the physician, any kind of clinical provider, whether it be nurses, physicians, whatever, they tend to know what their workflow is, and I think we have to adapt to that. Technology can improve that, and I think that we've seen that they're open to those, but we also have to be able to make that technology make their lives easier, make it less time consuming so they can spend more of their time with their patients or with their families or whatever they're trying to do.
Anybody else? Comments? Scott?
I'm sorry. Our discussion with the physicians was really about culture and workflow, and we really didn't discuss the technology that much. And we talked about culture, deliver the highest possible quality of care, make care more affordable, and delight patients. And here's the workflow that will accomplish this. And to be honest with you, that was 98% of the discussion with our physicians, and then 2% was probably on the how. So the technology, albeit extremely important, I apologize to everyone here, my information systems colleague, but I think the workflow and the culture was the part we spent the most time discussing with our physicians.
Yep. Anybody else?
Could
Steve?
I just add a caution that I totally agree. Workflow should drive technology, but there needs to be a meeting in the middle, right? If there is a completely acceptable technology-delivered workflow that could suffice, if we try to re-engineer that just because that's what we do, not invent it here, that seems wasteful. So there needs to be a meeting in the middle.
I think Steve put it practically. I'll add that for those of you that know what I did a few years ago with eConsult, when we launched eConsult countywide, we also spent, I'd say, about 90 to 95% of our time on what that workflow should look like and get that adoption and buy-in before we scale. But I do appreciate Steve's point that it is a marriage. You don't want to break one or the other, the effective value of each. Do you guys have a question? We've got about 5 minutes to go. I don't know if they have extra cookies outside or not. Any other questions for this group? Would you guys like to make any final comments, or do you have a question? I have one more I can ask. So the title or focus of this panel was Innovation in Healthcare Delivery. I think one or more of you touched a little bit upon what's happening 5 years, what's happening coming up forward-looking. My question to you is 5 years from now, 2020, where do you think technology will be? Where do you think healthcare delivery will be? What is the cool new thing or one of these technologies that's here on the hype cycle? What do you think will really achieve its fruition and actualization? What do you think will in 5 years' time we'll be talking about if we all had to come back here? What do you guys think? We'll start with Scott. Oh no, wait, Dave, go ahead, Scott.
Okay. Hopefully I don't have to come back here 5 years from now and defend whatever I say, because I'm sure I'll get it wrong. But I think they're just sticking with the theme because it's a broad question, so I'm just going to stick with what I presented. I think we're going to have guidance, professional guidance on all of our patients that will lead based on the evidence to the best quality, most affordable care, and I believe it will result in tremendous benefit from technology, measurable benefit, clinical benefit, save lives, reduce morbidity, improve quality of life, and make healthcare more affordable. That context-specific, professional clinician guidance.
Go for it.
Okay, sounds good. I think by 2020, most of the population will be under some sort of risk-based contract. from a population health standpoint. So what that's going to drive is really the individual taking more ownership of their care, which gets to what I mentioned earlier about the wearables and the sensors and things like that. You know, we'll all be connected in some way from the home to our care provider, you know, depending on, you know, what's happening with our health in our lives at a particular time. And that could be scaled up or down based on how healthy we are. And again, I think analytics will be an extremely important play in this because of the amount of data. If you look at, you know, 350 million people in the United States, and we're all in some sort of risk-based contract wearing these wearables with sensors, and it's all good, by the way, but unless that data can be managed in some way that the clinician can act on it, similar to what Scott's doing with his work, then, you know, it's all for naught. So I think, in my opinion, the analytics piece is really, we're really just at the forefront of that right now.
I would just say ditto, and just add that if you look at the way information has transformed retail, where you go and buy something at Walmart and within milliseconds it's being analyzed and decisions are being made, visibility and transparency of information, the last decade and a half plus has been data acquisition in healthcare, and going forward it's going to be data utilization and mining and socialized data, patient-reported outcomes, all of those. Data visibility is the general term I would use.
Go ahead, David. Oh, Carol.
I was just going to say, I think that much of the healthcare that we have today is going to be outside the walls of the hospital, mostly in the homes, in communities. It's driven by consumerism. We have a growing market there, and I think a lot of it will be done via mobile, via applications, et cetera. And we'll be, I think, seeing a tremendous amount of technology that drives that. The sickest of the sick will still go to hospitals. That's where they'll need to be, and I agree that risk-based is where we'll be probably in 5 years.
Go for it, David.
Yeah, I think, again, I'm focused in on glucose monitoring, and glucose will be an accepted vital sign in the hospital. And greater awareness of glucoses and ability to intervene to prevent high and low glucose will dramatically improve the lives and outcomes of people with diabetes.
And I'll end with something that we're all familiar with. Telemedicine, telehealth. Raise your hand if you heard about it 20 years ago, for those of you that were around that. It's been around for a while, right? It's now really coming into fruition. So I think, for my part, the technology around providing that instantaneous live communication, whether it's, you know, basic phone telecommunication or that live video consultation, I think you're going to see more and more what Jim mentioned, more of the teledocs, more of the American Wells, more of the e-consults that are exchanging. So we're going to walk around, we're going to have these devices, and as soon as reimbursement and provider, how physicians and physician groups and specialty groups kind of orientate their business model, you'll see more and more live consultations occurring. And it'll probably start out from the workplace, but I think that form of telehealth and telecommunication for consumers like us that are at events or out and about with our children or family, and an event occurs that we want to say, what is that? I want to, you know, get that instantaneous response. I think that's what's happening, because with consumers, it's all about the instantaneous response, the instantaneous text back and forth. So that's my 2 cents on the 2020. Are there any last questions? Any questions? If not, I think we're done. Give everybody a hand on the panel.